This is Lecture 12, Microbial Diseases of the Cardiovascular, Lymphatic, and Nervous Systems. And this is, I think, the most slides we see in any one lecture for the entire semester. And that's really mostly because there are so many different pathogens that attack the whole body, and so they really get thrown into the cardiovascular and lymphatic classes. There are others that attack the nervous system, and we will see those also. Because it's such a big group, that's really why this is so big, but also, as always, I'm pulling a few things out of the later lectures to put up front here. So again, instead of counting the slides and thinking about having to memorize all of the slides, look at what you are going to have to study. So look at the list of characteristics for a given disease that you have to memorize and go through the slides with an eye towards that. And you'll see there is a manageable number of diseases to learn about and a manageable number of pathogens. It is a lot, but it's not as much as the number of slides would indicate. So let's get into it. Right. So again, in Lecture 11, in that video, I gave some study tips, so you might want to check those out. Part 1 of this lecture. The first, I don't know how many slides, is microbial diseases of the cardiovascular and lymphatic system. So we'll go through the bacterial ones and then the viral ones. And let's think about these systems. So cardiovascular system and lymphatic systems, well, cardiovascular especially, is a closed system lined with endothelia. So the epithelial layers are not accustomed to ever seeing anything from outside the body. They're designed really to let fluid flow efficiently and to be sealed with some exceptions. And so our blood is protected by various cells that clean debris out of the blood. But bacteria do get introduced into our blood in various situations, like flossing our teeth and things like that. And usually the phagocytes in the liver and the spleen are more than able to remove any bacteria from our blood. We get into problems when bacteria in our blood are able to reproduce there. If they're able to grow, they can grow faster than the phagocytes can take them out. And they can damage tissues and cause large amounts of inflammation. That could be dangerous. So that's what we're going to see in a lot of cases. So we start with the bacterial diseases. One you may have heard of is blood poisoning. And I remember reading about this when I was young, where we start to see red streaks going towards the center of the body from the site of an infection. And what's happening here is the lymphatic system is transporting many different things from the site of infection, and so we see inflammation along the route of a lymphatic vessel. There are different ways this can happen. If the bacteria spread from the lymphatic system to the blood, that can be a problem. But this by itself is not a sign of anything severe happening. So this isn't itself blood poisoning. So this is really an infection of lymph. Sepsis is real blood poisoning. So when we see bacteria growing in the bloodstream or huge amounts of bacteria from a tissue entering the bloodstream and a whole body immune response against that, that's kind of out of control, that's sepsis. And sepsis is extremely serious. And one of the most important things you can get if you're going to be a clinician is knowledge of sepsis and the ability to potentially recognize it and draw a clinical team's attention to it. Sepsis is complicated. it's hard to predict and diagnose and treat. So the issue is that there are a lot of different things that can cause sepsis. Fungi, protists, bacteria can all do this. And depending on exactly how the immune system responds to them, you'll see different signs in the case of sepsis. And often a patient will be so sick that they won't be telling you about their symptoms. So you really are looking for the signs. I can't give you a diagnosis guide to sepsis. That wouldn't be appropriate since I'm not a clinician. And I'm not teaching you how to diagnose anything. But it's important to me that you can be the eyes and ears so that if you ever see someone who has the signs of sepsis, you can get someone's attention. Because the earlier we recognize that this is happening, the higher chances of successfully treating it. So there are lots of different types of infections that can lead to sepsis, but the point is anytime bacteria can be in the bloodstream in large numbers and actively growing there, the immune system will respond. If large amounts of peptidoglycan or lipopolysaccharide are circulating in the blood, then many parts of the innate immune system recognize that and respond. And so if we have a lot of bacteria in the blood, or even a lot of fungi in the blood, they have their own molecular patterns that we can recognize. If those things are in the blood, our immune systems have big responses. And so this is very dangerous in very young children and older people. And so sepsis, it's I'm not sure whether it's a growing problem or a problem we're doing better to recognize, but often this is what ultimately leads to a person's death, and we don't know exactly how common it is because in a lot of cases it wouldn't be listed as the cause of death. Part of the problem with sepsis is that we don't have good research into it. Part of my own PhD research was trying to develop a sepsis model organism, and I was my project was one of hundreds, and there are lots of really elaborate and very sophisticated mouse experiments where they try to use mice or rats as models for sepsis, and develop drugs that can treat it directly, and they've never really led to any human drugs for treating sepsis. It's unfortunate, but it's true that our immune responses are different enough from the immune responses of other animals that we can't always directly connect the two during research. So that's unfortunate. All we can do is rapidly diagnose it and rapidly start treating it with antibiotics and whatever else we need to reverse the problems that are caused by sepsis. And so again, I want everyone to be the eyes and ears to perhaps recognize sepsis early on and get the attention of someone who can diagnose and treat it. So this bright yellow slide is common signs of sepsis, and I do want you to learn this list. This is the only slide I can think of that I want you to memorize the entire list, and it's not very long. What I should tell you is, since I'm not a clinician, I'm not comfortable whenever I have to give clinical information, so I go looking and spending a lot of time trying to make sure all of this is right. And what I found for sepsis is lots of conflicting information. Ultimately, the problem is that it doesn't always look the same. And like I said, different microorganisms and different people's immune responses will lead to different signs. So you cannot ever assume that you will see all of a certain sign. Not every sepsis patient will have all of these signs. But if you see someone who looks very ill and has fever, rapid breathing, rapid heart rate, and high white blood cell count, so all of these signs, that is a very good indicator that they have sepsis. Other things that happen, a patient will become confused. A patient will become confused and perhaps develop a purple rash or small red spots. But even if you see 3 of these, that's a sign sepsis might be happening. And so there is no definitive list of what to expect when someone is going through sepsis, and that's part of why it's hard to identify and part of why it's a problem. People don't always notice it when it's happening. Okay, so why is sepsis such a big deal? All we've talked about is an immune response to microorganisms. Well, what can happen is septic shock, and that's where the extreme amounts of inflammation that are happening ultimately cause a drop in blood pressure, because white blood cells are leaving the blood and ultimately perforating a lot of capillaries. And so it's hard to keep the blood pressure high enough to get oxygen to the organs. And so septic shock, I have seen a definition for septic shock where it said that medical intervention is necessary just to keep the blood pressure at a very low level. I don't remember what the level was. It doesn't matter. But it's that without medical intervention, the blood pressure will drop to fatal low levels. And so even with intensive care, a person in septic shock has a significant chance of dying from it because of multiple organ failure they'll experience, or potentially severe intravascular coagulation. And so rapid identification of sepsis to prevent septic shock, rapid treatment of sepsis to prevent septic shock is an important thing that anyone working in a clinic can be aware of. So, okay, that's sepsis and septic shock, and that's something we focus on specifically at Lane, making sure everyone who takes our microbiology classes is aware of it. So the next thing we move to from there is bacterial endocarditis. This is where bacteria infect heart valves, or the endocardium, so the epithelia surrounding the chambers of the heart. This can happen for different reasons, but what it normally involves is some kind of damage to the endothelium for whatever reason, some kind of damage to a heart valve that allows spaces for bacteria to stick. And they can do things like start growing in biofilms and start causing fibrin to collect around them. And both of these things prevent things like phagocytosis, and they also change the bacterial physiology so that many antibiotics are less effective than they would be normally. And there are a lot of reasons for that. If bacteria grow slowly, beta-lactam antibiotics don't work. Because if bacteria aren't remodeling their peptidoglycan, if they're not making holes and trying to fill them in, there's nothing for beta-lactams to do. And there are other antibiotics that work in different ways, a lot of ribosome inhibitors. They have to be actively imported by bacteria, and bacteria in the center of biofilms don't do that. So there are a lot of reasons for this, but basically it requires very high concentrations of antibiotics to damage cells if they're inside these vegetations and biofilms. So endocarditis, bacterial endocarditis, is hard to treat and very dangerous. So there are 2 types, acute and subacute bacterial endocarditis. The acute type is rapid and very dangerous. It's invariably fatal unless treated. And so the way we treat it is with high doses of antibiotics. How this happens is large doses of skin bacteria are introduced into the bloodstream. And so that can be Staphylococcus epidermidis, Staphylococcus aureus, and a lot of strains of these two are quite capable of growing in the blood and infecting a heart valve or damaged endocardium. And what else? Yeah, so that's all things I've talked about. Subacute, well, just to back up, again, the most common cause is intravenous drug use, because people will eventually lose the deliberate hygiene that you see in a clinic when someone uses a needle, where they have to disinfect the skin and all that first. What happens if you don't disinfect the skin effectively before using a needle can be acute bacterial endocarditis. Subacute bacterial endocarditis is usually caused by different bacteria. Usually it's from bacteria from the mouth that are introduced during dental work or bacterial flossing, anything that causes a lot of bleeding in the mouth. And introducing these bacteria into the bloodstream is common, and it happens to healthy people, and they don't get bacterial endocarditis. But people who have a history of valve diseases, so problems with their heart valves, or if they've had rheumatic fever as a kid, we'll cover this, I think, in lecture 13, they can have damage to the heart lining, and that can predispose them to subacute bacterial endocarditis. And so we treat this the same way we would treat the acute bacterial endocarditis, because ultimately the same thing is happening. There are bacteria growing in vegetations and biofilms on heart tissue. So here is some details about the pathogenesis to help you understand exactly the procedure that happens here. And ultimately this can lead to damage to a heart valve, so decreased heart function, and potentially heart failure. But there are other things that happen, like blood clots in the blood. Those can damage a lot of different organs. And if enough bacteria are being released, that can cause sepsis. So lots of bad things that can happen. One thing to note is, depending on which part of the heart is affected, you might get different signs. So the right ventricle, for example, if that's affected, then bacteria and the fibrin clots and all that released from that infection will end up in the lungs, and the lungs effectively filter or trap blood clots. So my understanding is that a lot of small blood clots that might happen in the body end up getting trapped in the small capillaries in the lungs. And those capillaries are so numerous, we never know about this. It's not a problem for us to lose a significant fraction of them to blood clots, small blood clots. But if you have a lot of that happening, or large blood clots being trapped in the lungs, you would see respiratory signs. And then again, if this were happening in the left ventricle, it would lead to systemic problems with bacteria and clots material going through the body. So that could damage any organ. And if it hits the kidneys or the brain and shuts them down, well, that would obviously be fatal. Rheumatic fever is it's a complication of strep throat. I completely forgot mentioning it here, but yeah, this is a complication of strep throat that can lead to damage to heart tissue because it leads to inflammation of the heart. So this is no longer as common as it was in the US, because now we identify bacterial pharyngitis, like strep throat, and we can treat it with antibiotics. So in places where we can't do that, in a lot of developing countries, this still does pose a big threat to children. There are a couple major virulence factors in streptococci that make this more likely. One is that Streptococcus pyogenes, which causes strep throat, this is also known as the group A streptococci, they have a capsule that mimics host hyaluronic acid, and so that mimics being part of a host cell. So it hides in that way. And also it's covered with M proteins, and they can do things like disrupt the complement system, avoid opsonization. So those are some potent virulence factors. So that's plenty for this first video. This went kind of long. I wanted to start strong. So good job keeping up. In the next one, we will jump right into bioterrorism.